Multiple sclerosis is one of the most common diseases that causes white matter lesions on MRI, but sometimes it's not MS. In this video, I'll show you examples of other diseases which could be mistaken for MS. This is a time-lapse video of an MRI done every 2 weeks over 1 year in someone with MS who is reportedly stable. You can see MS plaques tend to be ovoid in shape, and in certain locations, such as around the ventricles, the juxtacortical area, the corpus callosum, brainstem, cerebellum, and spinal cord. Keep that in mind in contrast to the images I'm going to show you. This is an MRI of the orbits in a 46-year-old woman with vision loss in both eyes. On the left, we see a coronal image like this. These are the optic nerves and the extraocular muscles, and these are axial images. Of course, people with MS can get optic neuritis, but here the abnormality is different. It's around the eye. You can see the contrast enhancement. This is optic perineuritis, completely inconsistent with MS. You can see the donut sign or tram track sign on axial images suggesting of an abnormality around the optic nerve, not within the optic nerve itself. This woman tested positive for anti-MOG antibodies and hence has myelin oligodendrocyte glycoprotein associated disease or MOGAD, though optic perineuritis can occur with various rheumatologic or infectious diseases. This is an MRI of the thoracic spine. On the left we see sagittal images like this, and you can see this white abnormality. This is longitudinally extensive transverse myelitis, very uncharacteristic of MS, which usually causes short 1 to 2 vertebral segment areas of abnormality. On axial images on the right-hand side, you can see the lesion is in the center, more towards the gray matter, atypical of MS, which tends to be more posterior or in the lateral spinal cord. This MRI is from someone with neuromyelitis optica associated with anti-aquaporin 4 antibodies seen in 70% of people with the condition. The same antibodies are associated with lesions in the optic nerve and optic chiasm. Here you can see heavy enhancement of the optic chiasm. This isn't a finding we would typically see in MS. This could cause severe vision loss. You can also get lesions in the corpus callosum here, but unlike the white picket fence signs seen in MS, you see this continuous lesion along the entire callosal surface, the so-called dot dash sign. You can also get brain lesions in neuromyelitis optica. This lesion could look like an MS juxtacortical lesions, but you can also see more fluffy, diffuse, unusual looking lesions in NMO. Here's an MRI of the cervical spine. You see this impressive enhancing lesion, but if you look closely, it looks like it may be coming from outside of the spinal cord in the meninges. Further evaluation with the PET scan showed uptake in the hilar lymph nodes. These are the lymph nodes near the bronchi and the mediastinum, the tubes going to the lungs. This is consistent with sarcoidosis, an autoimmune disease which usually doesn't affect the nervous system. It can affect the lungs and the skin. It's the disease the late comedian Bernie Mac had, but sometimes it can affect the dura in the brain and spine. Sometimes on axial images, you can get these enhancing lesions in the lateral and posterior aspect and even the center of the cord, achieving this so-called trident sign, but this is actually rare. This MRI is from a 62-year-old man with a long, slowly progressive history of cognitive impairment. Some of the lesions could be mistaken for juxtacortical or subcortical lesions, though if you look closely, there aren't really periventricular lesions, and many of the lesions have a fluffy appearance, more typical of vascular disease. Also, this heavy involvement of the bilateral anterior temporal lobes is highly atypical of multiple sclerosis. This gentleman actually has CADASIL, a genetic disease, cerebral autosomal dominant arteriopathy with subcortical infarcts and leukoencephalopathy caused by a mutation in the Notch3 gene on chromosome 19 and inherited in autosomal dominant fashion. It's known to be associated with migraines. This MRI is from someone with poorly controlled high blood pressure and rapidly progressive cognitive decline. Although advanced MS can cause confluent lesions, these lesions are very indistinct with fluffy borders, atypical of multiple sclerosis, and they're much more consistent with vascular disease, and these are in fact small infarcts accumulating in the brain, and when they cause rapidly progressive dementia, it's known as Binswanger's disease. This 61-year-old woman had vertigo, vomiting, memory loss, and even hearing loss. MRI of the brain shows these lesions in the corpus callosum, which do look like multiple sclerosis, but some of them have an unusual circular or snowball appearance atypical of MS. Also, a preponderance of the lesions are within the corpus callosum, which is a little atypical of MS. If you look at the contrast-enhanced MRI, you can see these radial linear lesions, very atypical of MS, and even leptomeningeal enhancement. Of course, this is more typical of vasculitis, inflammation of the blood vessels of the brain. Further evaluation with a scan of the retina, a fluorescein angiogram shows dye leaking out of the blood vessel and even occlusion of blood vessels consistent with a retinal vasculitis. This is all consistent with Susac's disease, a rare autoimmune disease more typical of a younger woman, median age around 18, very atypical in a 61-year-old, but it can occur. She was treated with high-dose solumedrol steroids for 5 days and oral prednisone and the long-term treatment azathioprine, and dramatically improved over time. By the way, these are from real case reports, citations in the notes below. This 52-year-old man had gradually worsening memory loss and a change in personality described as being more withdrawn and aggressive. He had difficulty looking upwards along with numbness and tremor, and MRI showed these confluent white matter lesions around the ventricles, and some people with multiple sclerosis could have a similar MRI. There's also extensive atrophy. You can see the large lateral ventricles. However, his brother had similar problems in his 50s and was diagnosed with the aforementioned CADASIL, and his mother and sister also had an undiagnosed progressive neurological disease. No diagnosis was made until he passed away 11 years later. Autopsy revealed this. There were macrophages, white blood cells, but these unusual axonal spheroids staining positive for amyloid precursor protein. But this isn't Alzheimer's disease, it's actually a rare genetic disease, hereditary leukodystrophy with spheroids, an autosomal dominant disease, hence his family history caused by the CSF1R mutation. I've tested this in some young people with primary progressive MS, but it's always been negative. This 38-year-old Chinese man had a seizure, and MRI revealed 4 brain lesions thought to be inflammatory. This was thought to be a form of demyelinating disease. Now, Asian people have a lower risk of MS, roughly 1/10 the risk in the United States compared to other ethnicities. In China, it's much, much lower, though we should keep an open mind. He was given steroids, but had another seizure, and subsequent MRI revealed the lesions had steadily grown, atypical of MS, and he actually had a brain biopsy and was found to have a tumor. Sometimes brain tumors, not metastatic tumors coming from somewhere else, can be multifocal. I, in fact, had a patient who was a young woman who had multifocal glioblastoma multiforme, grade 4 astrocytoma, who was misdiagnosed with multiple sclerosis initially. This gentleman was lucky. It was a lower grade tumor, grade 2 astrocytoma, highly unlikely to be multifocal like this. He was treated with temozolomide and radiation therapy, and follow-up MRI showed the lesions were dramatically improved. This 26-year-old Nepali woman had imbalance and dizziness. MRI shows these unusual speckled enhancing lesions in the pons and cerebellum. She dramatically improved with steroid treatment. This is Clippers, chronic lymphocytic inflammation with pontine perivascular enhancement responsive to steroids. This is the first reported case in Nepal, according to the case report. This is a 66-year-old man with progressive imbalance and falls, which developed very gradually. On the right, you can see this axial image shows periventricular lesions that are somewhat confluent that could be consistent with MS. Here in the brainstem, you can get middle cerebellar peduncle lesions in MS, but they're so perfectly symmetrical. This is the key image here. This is Fragile X-associated tremor ataxia syndrome, a genetic disease. It's caused by the same trinucleotide repeat in the X chromosome, CGG, that repeats over and over again, that causes Fragile X syndrome, the developmental disorder in children, but with shorter repeats, you can get a milder disease that causes symptoms much later in life and is often undiagnosed. This is an MRI of someone with imbalance and diffuse unexplained pain. MRI shows these unusual patchy lesions in the pons, cerebellum, and right temporal temporal lobe with partial enhancement. Atypical of multiple sclerosis, we would usually see more well-demarcated lesions in the pons and cerebellum. Unclear the diagnosis from this MRI. Further evaluation included a scan of the long bones. These are the knee joints, the femur, and the tibia, and you see these large sclerotic lesions. This is actually metastatic cancer. This is Erdheim-Chester disease caused by non-Langerhans cell histiocytosis. I have a patient with very similar clinical symptoms and MRI, this is not my actual patient, who did very well with chemotherapy. This MRI shows something outside of the nervous system. You can see enhancement of the meninges, the coverings of the brain, and in the cavernous sinus and the area of the superior orbital fissure. There's also a mass pushing on the upper thoracic spinal cord, but you can see it's coming from the dura, not the spinal cord itself. There are various diseases that can cause this picture, the aforementioned sarcoidosis, certain types of cancer or infections like tuberculosis, or a condition called idiopathic hypertrophic pachymeningitis. But this is actually IgG4 related disease, where immunoglobulin G4, this subclass of immunoglobulin G, is sky high in the blood, and the test to order is immunoglobulin subclasses, and biopsy will also reveal extensive plasma cells and immunoglobulins. It most typically affects other organs such as the pancreas and the gastrointestinal tract, but can also affect the nervous system. It can respond to immunosuppressant drugs. This 48-year-old Chinese man had progressive sleepiness and memory loss over 4 months. This MRI really isn't typical of multiple sclerosis. You can see there's a lot of involvement of the gray matter, the caudate nucleus here, the diffuse involvement of the midbrain, and these unusual lesions in the anterior inferior frontal lobe, not typical of MS. He actually has lymphoma, a cancer of the white blood cells. Beware that steroid treatment can cause transient resolution of the lesions, though they'll always come back if not treated with proper chemotherapy, though it can be curable in some cases. This 64-year-old man who uses dentures has progressive numbness of the hands and feet and difficulty walking. This is an MRI of the cervical spine. These are sagittal images, and you can see this long symmetrical lesion, and on axial images you can see it's very specifically in the posterolateral spinal cord. This is actually subacute combined degeneration, a disease most commonly caused by B12 deficiency, but in his case it's a similar disease caused by copper deficiency. Denture cream used to contain zinc, which competes for copper absorption in the gastrointestinal tract, and chronic use of high amounts of zinc can be very dangerous because they cause copper deficiency. This is an MRI from someone with progressive weakness and upper motor neuron signs. These are physical exam findings consistent with central nervous system injury, such as very brisk reflexes. On coronal images, you can see this lesion looks like a U-fiber lesion, which could be consistent with MS in the motor area. However, on axial images, you see these very symmetrical lesions in the posterior limb of the internal capsule, atypical of MS, but are consistent with primary lateral sclerosis. This is a disease similar to ALS, or amyotrophic lateral sclerosis, or Lou Gehrig's disease, but instead of both the upper and lower motor neurons being affected as in ALS, in PLS only the upper motor neurons are affected, and the disease tends to be milder and more slowly progressive, but be forewarned, this diagnosis is very frequently incorrect. So I hope that was informative. Please ask questions in the comments below. Also note this is essentially a remake of a similar video called Multiple Sclerosis Mimics 5 years ago, and if you want to see some other examples of MRI scans of diseases that mimic MS, I'll include that video in the notes below, and let me know if you have ideas for future videos.